On strategies in immuno-oncology. My name is Patrick Autumn. I'm from the Dana-Farber Cancer Institute in Boston. This session will cover 4 different early clinical trials conducted in a broad spectrum of cancers, including anti-PD-1 resistant melanoma, neuroblastoma, a rare childhood cancer, non-Hodgkin lymphoma, indolent type, as well as GI cancers. The therapeutic approaches discussed in the sessions are diverse and include a TLR agonist paired with PD-1 inhibition, adoptive transfer of NK cells, CAR T cells directed against a solid tumor antigen, and an IL-15 receptor agonist in combination with CD20 inhibition. The wide spectrum of disease settings and variety of different approaches tested in the clinic showcased in this session nicely illustrate the stature of immunotherapy within the field of cancer therapeutics today. The broad single-agent activity of PD-1 pathway inhibition has provided proof of principle for the efficacy of cancer immunotherapy and has led to the exploration of wide-ranging strategies to tip the balance between an effective and an ineffective immune response against the tumor in the host. These strategies also include the resurrection of approaches that seemed to have largely failed in the past, including cytokines. The format of the clinical trial plenary session is somewhat unique, as it will feature 2 presentations for each clinical study presented. One describing the clinical trial, and it will be immediately followed by a discussion that's focused on the science informing the clinical trial. I'm told that we won't have any time for questions, but I think we can play it by ear just depending on how the session goes. So that said, I would like to invite the first speaker, who is Dr. Mo Milham from the Holden Comprehensive Cancer Center at the University of Iowa. He will present a study testing the TLR9 agonist CMP-001 in combination with Pembrolizumab in anti-PD-1 resistant melanoma.
Good morning. I would like to thank the organizers for inviting us to give this talk. My name is Mohammed Milham, and on behalf of the other investigators on the team, I'd like to present to you our data. I have no financial disclosures to disclose, or financial relationships to disclose. I will discuss the following investigational agent in my presentation, CMP-001 in combination with Pembrolizumab in subjects with advanced melanoma. Many tumors contain plasmacytoid dendritic cells. These inhibit the microenvironment and prevent rejection into tumor level, and they also support Tregs and MDCs. In the presence of an injected CpGA, TLR9 is bound by the CpGA on PDCs, resulting in an active state. These activated PDCs secrete large amounts of type 1 interferon, as well as Th1 chemokines, changing the microenvironment to the classic inflamed type. This results in T cells that are generated that can mediate tumor rejection, both in the injected tumor as well as in the uninjected tumor. CMP-001 is the study drug that we will be discussing today. It is made up of 2 main components. CpGA, or G10, is a 30-mer native DNA oligonucleotide. That is the first component and the most active component. The second component is a purified coat from the Q-beta bacteriophage. This virus-like particle has no viral genes and is non-replicating. It protects the CpGA DNA from degradation and also allows for TLR9 receptor uptake. The main mechanism of action leads to this activation of plasmacytoid dendritic cells, mainly through TLR9 agonists and signaling. This is a phase 1b study. The design was a 3+3 dose expansion and escalation. CMP-001 was injected intratumorally, and Pembrolizumab was given as per label IV. 2 CMP-001 schedules were used, a weekly ×7 and a weekly ×2, followed thereafter by every 3 weeks until discontinuation. Scans were done every 12 weeks, and we assessed, the investigators assessed tumor responses by RECIST 1.1. CMP-001 was given over a number of cohorts ranging from concentrations from 1 milligram to 10 milligram over two main concentrations, a low and a high. The maximum tolerated dose was not reached. We settled on a dose expansion phase with 5 milligrams low dose weekly plus Pembrolizumab, and I'll expand a little bit further on why this dose was particularly selected. It was up to the investigators to increase the dose up to 10 milligrams since the maximum tolerated dose was not reached. The key inclusion criteria: subjects had to have metastatic unresectable melanoma. In the dose escalation phase, prior best response to anti-PD-1 based therapy was progressive disease or stable disease. In the dose expansion phase, we allowed patients who had progressed on anti-PD-1 based therapy to enter regardless of their best response. There was no restriction on the number of lines of therapy that patients were allowed. Key exclusion criteria: there was a 30-day washout for investigational agents as well as anti-CTL4. No steroids were allowed more than 10 milligrams per day. Grade 4 autoimmune toxicity as well as on prior immunotherapy was excluded, and CNS metastasis, active CNS metastasis, was excluded. We've taken the liberty of just sharing with you some of the subject characteristics of note. The best response on prior anti-based therapy, this is for the dose escalation as well as the expansion. You can see that some patients had an initial response to anti-PD-1 of about 7%, and progressive disease made the majority at 58%. However, the overall response to prior PD-1 based therapy at entry into the study, progressive disease at 91% and stable disease at 9%. The median number of lines of therapy were 2, and we had a whole host of different types of immunotherapies that we did, that the patients entered into the study. I will select some cases just to share with you the flavor of what those subjects look like. All stages, unresectable and metastatic, were included, and the major sites of CMP-001 injection were skin, lymph nodes, and soft tissue, as you can see. And one subject actually had a liver lesion, injected visceral lesion, and tolerated this relatively well. In this slide, we're sharing with you the adverse events that occurred during the intratumoral injection of CMP-001 in the presence of Pembrolizumab. The major symptoms were flu-like symptoms: chills, pyrexia, nausea, fatigue, headache, and vomiting, all known to those who give immune drugs. If you look at the grade 3 adverse events, the main one that stands out is hypotension. This hypotension was responsive to fluid resuscitation, and in some patients required stress dose steroids, but generally well tolerated. Most of these side effects occurred 1 to 4 hours after the CMP-001 injection, and a lot of them were manageable and monitored quite easily with symptomatic management. This is our waterfall plot for the best tumor responses of all subjects, injected and non-injected. This is for both the dose escalation as well as the expansion phase. You will note that we did see some CRs, some PRs, as well as stable disease. In this slide, we're showing you the responders. Specifically, we've divided them into two main groups, those on the left and those on the right. The ones on the left are the subjects with injected target lesions only. On the right, the subjects have both injected and non-injected target lesions. The axis is the RECIST responses, as you can see. We did see a local and a systemic response. This is a spider plot that shows the change from baseline in the target lesions for all subjects. Very interestingly to point out in this particular slide is the depth and rapidity with which tumor burden was decreased. As you can see, this is quite obvious. There was also a very long tail, as is usually seen, so the responses were durable, as usually seen with other immune therapeutics. In this slide, we're going to share with you the objective responses and the reason for the selection of the dose expansion phase. Starting to the left, we have 69 subjects in the dose escalation as well as expansion. The overall response rate at this time is 22%. There was an increase towards the weekly dosing versus the Q3 weekly dosing, favoring the weekly dosing, which is one of the reasons why we chose it. This was not statistically significant. There was also an increase towards a response in those who had a higher volume of the drug given than a lower volume, again, not statistically significant. We are currently in the dose expansion phase. We have 21 patients currently accruing. Our overall response rate so far is 24%, and we plan to accrue 50 to 60 subjects on this trial. In this slide, we're showing the overall response rate with regards to tumor burden, low versus high. If you look at the low versus high, we can see that both cohorts actually did respond, with a tendency towards the lower burden, as is normally seen with other immune therapeutics. This is a swimmer's plot of all the responders, of which I will take a little bit of time just to share with you some of the results. As you can see, the majority of the patients passed 6 months, and several have passed a year. There are some patients that are currently off therapy and still continue to have a response. There are 3 patients that had an initial progression by RECIST, but were allowed to continue and then showed a response. 13 out of the 18 responders remain on study, and the median duration of response has not been reached. As I mentioned, I was going to go through some of the cases so that you can understand some of the patients and what treatments they had before and some of the responses that we were seeing. This is a 48-year-old with metastatic bilateral lung disease that progressed on prior therapies of adjuvant interferon, Pembrolizumab, aflibercept, IL-2, and ipilimumab. The injection site was the distal site, the inguinal lymph node. As you can see by the CT scan, there are lesions inside the lung, and within 12 weeks, you can almost see that there is a response that is very much more pronounced at 48 weeks. This is an ongoing response, more than 84 weeks, with more than 70% reduction in the tumor. This is a 59-year-old with metastatic disease to the spleen, chest wall, jaw, and cervical lymph nodes. This is a patient I personally treated. Patient progressed on prior therapies with decitabine plus vemurafenib, pembrolizumab, ipilimumab, dabrafenib, and trametinib. The lesion in the jaw was causing a lot of symptoms with trismus and appeared very rapidly. There were lesions in the viscera, including the spleen. And within 12 weeks, we saw more than 95% reduction in the tumor volume with the complete absence of the injected site, as well as that of an abscopal effect inside the spleen. This is just to show you again that we did achieve complete responses in patients. This is 77 with unresectable disease of the scalp that progressed on prior pembrolizumab. This was the injected site. 100% reduction in the tumor size ongoing for more than 48 weeks. In this case, we are highlighting a case where multiple injections, multiple sites of injections were done because of the response that we saw in each of the injected sites. We also document a pathological complete response. This is the baseline scan of a patient or subject that progressed on interferon, pembrolizumab plus an IDO inhibitor, and ipilimumab plus an IDO inhibitor. The lesions were injected, and this is 1 year after the injections of the lesions. You'll see some hyperpigmented lesions with some vitiligo around it. A biopsy of this lesion showed a lymphohistocytic infiltrate with melanin-laden macrophages with no tumor seen. This was done on 2 sites, and we deemed this patient to have a pathological complete response. The patient is actively not receiving therapy, neither with the injection nor with pembrolizumab, and is doing very well. Shifting gears and going to our translational analysis, we looked at immunohistochemicals analysis of CD8 and PD-L1 expression in a subset of patients who received biopsies before and after therapy. We compared CD8 as well as PD-L1 expression in baseline in the injected and non-injected, and we did see and appreciate an increase in CD8 as well as an increase in PD-L1 expression. We also did RNA-seq in a select group of subjects that had a pre- and post-biopsy following therapy. We were looking for an association with T-cell inflammation or genes that are associated with T-cell inflammation. In this heat map, you can see the subjects on the right are the ones that responded, and that the heat map shows a T-cell inflamed signature that is more in the ones that regressed initially, as in this subject, and had a partial response in this subject, but not in the two subjects that were rapidly progressing. Notably, the genes that were increased or are shown to be increased were those that were seen with TLR9 activation. Finally, in 16 patients with pretreatment biopsies, we looked at the intratumoral PDC percentage. This was determined through IHC analysis. As you can see to the left, patients who had a higher content of PDCs initially had a partial response to stable disease ultimately, and those who did not had progressive disease. This could be an enrichment biomarker that could potentially help us enrich for this patient population. In conclusion, the intratumoral TLR9 agonist CMP-001 in combination with Pembrolizumab can reverse resistance to PD-1 inhibition in melanoma subjects who have progressed on anti-PD-1 therapy. The combination of CMP-001 and Pembrolizumab appears well tolerated and can produce deep and durable systemic clinical responses. Results from IHC, RNA-seq, and chemokine analysis are consistent with activation of plasmacytoid dendritic cells by CMP-001 through TLR9 signaling. Enrollment into the expansion phase of the study continues, and clinical investigation in other tumor types is underway. I would like to thank specifically the patients and the families who are really the true heroes of this clinical trial, as well as the many institutions that participated in bringing this trial to life. Thank you.
Thank you, Dr. Wolf. I'm going to ask Dr. Jed Walchuk to the podium from Memorial Sloan Kettering Cancer Center to discuss, or we could squeeze some questions in between. Maybe we'll do a little question round. So are there any questions? I would be interested, did you actually look between the lesions that were injected and non-injected in terms of the infiltration with CD8 cells and PD-L1 expression?
Yes, we did.
And did you see any differences?
We saw infiltration in both the CD8 and PD-L1 expression. We saw an increase, more in the injected than in the non-injected, but they're variable.
Okay. And did you look at CD4 cells with IHC?
I don't think we did.
Okay.
But something to go back and do.
Okay. Microphone number 2.
Responses in patients where a PD-1 inhibitor was the immediate prior therapy. That means they're actually progressing on a PD-1.
Can you repeat the first part of the question? I didn't quite hear it.
Do you have responses in patients that had a PD-1 inhibitor as an immediate prior therapy?
Yes, many responses.
Okay.
Do you have any information on the PD-L1 staining status prior to the initiation of this therapy or at some earlier time?
We didn't really look at PD-L1 status prior to entry into the study.
Thank you for this beautiful presentation. Have you injected visceral lesions like lung, liver?
So one subject was injected inside the liver and tolerated this really well.
Thank you.
Very nice work. One question about the biomarker that you detect very nice dendritic cell increase as well as the transcriptional profile change. How many doses you are going to see that in your study? Is that after one dose and the 7 days you can detect that, or you need to have multiple doses, so 3 weeks, something like that?
So that's a very good question. I think when we did the biopsies, we did it after one dose, so it's really hard to tell you that it was after multiple doses. We did see an inclination towards more responses when we gave the weekly dosing, so that was one of the reasons why we continued with the weekly dosing as in our dose expansion. So I would say probably more is better.
But at least after 7 days, one dose, you are able to see those.
The response is incredibly rapid. I will tell you that if in the lesions that you can see on the skin with the one injection, they flatten out almost within a week. You're bringing to light something that is quite rapid.
Thank you.
We'll do one more question.
Outstanding and provocative data there, Mo. I have a question about whether or not you were able to evaluate at baseline and perhaps subsequent after treatment the expression of potential JAK or beta-2 microglobulin mutations in these patients who had all progressed with prior checkpoint inhibitors.
That's an excellent question. Something to do. We still haven't reported on all our analysis. So.
Okay. Thanks, Dr. Millam. I'm going to ask now Dr. Jed Walchuk from Memorial Sloan Kettering Cancer Center to discuss this presentation.
Okay, thank you, Dr. Ott, and congratulations to Dr. Milham and the team for a wonderful presentation and a very exciting trial. Okay. You know the title of the actual abstract, but I'm going to sort of subtitle this a TLR9 agonist as an oasis in the immune desert. These are my disclosures. So I'm going to give a very brief review of the PD-1 pathway and what has been achieved thus far, specifically in the treatment of patients with metastatic melanoma. As many of you are no doubt aware from many fantastic presentations at this meeting and others, the PD-1 pathway has really emerged as being foundational in restraining the immune response to cancer. And melanoma is one of the diseases where this pathway has considerable activity. And when it is blocked, we see very impressive responses, as I'll show you in about 45% of patients. As many are aware, PD-1 is a molecule which is upregulated on T cells after they become activated. One of its ligands is sensitive to interferon gamma signaling in the tumor microenvironment, and PD-L1 is upregulated in a mechanism termed adaptive resistance by Suzanne Topalian and Drew Pardol, and this then silences signaling coming from the T cell receptor, disabling the immune response. And therefore, on the right side of the slide, blocking this interaction between PD-1 and PD-L1 with antibodies to either component leads to really a reinvigoration of this response. This is a very brief timeline that was put together by Tony Rebus and myself in a recent review showing how quickly the number of PD-1 blocking agents have evolved into routine approved clinical use for a long list of diseases, either alone or in combination, in this case, with ipilimumab. Some of the earliest data showing activity of PD-1 pathway blockade with Pembrolizumab was this data presented by Tony and then published shortly thereafter by Caroline Robert, was in patients with either ipilimumab untreated or ipilimumab refractory melanoma, and showed quite clearly that blocking PD-1 was a very potent intervention in patients who have either been exposed to CTLA-4 blockade or not. This data led to FDA approval of Pembrolizumab and investigation in many settings, including the Checkmate 67 trial, which showed, in fact, that we could achieve durable responses with PD-1 blockade alone, in this case with nivolumab, the blue line, because this is from a study that looked at patients with melanoma treated with nivolumab alone, ipilimumab alone, or the combination of the two. And you can actually see the progression of care in a very short period of time in patients with metastatic melanoma, looking at 3-year outcomes in terms of overall survival, increasing with different interventions. However, the fact that all of those curves do not plateau at 100% reminds us that we still have much work to do, that there are patients with melanoma, there are patients with other cancers who are either primarily refractory to PD-1 pathway blockade, or who have tumors that initially respond and then become resistant. And you heard in the question session some of the reasons for those patients who develop sort of acquired resistance is through loss of critical signaling or antigen presentation molecules. We are now assembling a list of features that we believe influence resistance or refractoriness to PD-1 blockade. As many have heard yesterday, tumor mutational burden is a major influence. The presence of suppressive cell subsets in the tumor microenvironment, whether these be regulatory T cells or myeloid-derived suppressor cells, is important. Defects in antigen presentation machinery, such as TAP deficiency or loss of beta-2 microglobulin, which has been recently demonstrated, are also important modulators of resistance. We are also aware that insufficient co-stimulation can lead to a suboptimal immune response, as can defects in the effector mechanism, again, JAK mutations or mutations in the interferon gamma signaling pathway. This also leads to some categorization of different tumor microenvironments where some sort of non-inflamed tumors have been referred to as being cold or desert-like, and I think the irony there is interesting, and opens the door to really how to consider how do we change a cold or non-inflamed microenvironment into one that is more amenable to the initiation of an immune response. Because we also now recognize that the patients who are benefiting from PD-1 blockade are those in whom there is a baseline immune response that needs to be disinhibited. And if these patients, due to any of these features, have a suboptimal immune response at baseline, we need to provide additional perturbations to enhance that. This has been very nicely summarized by Preeti Hegde, who really was the first person I heard use the term the immune desert, based upon a close look at tumor biopsies, where you can either see pre-existing immunity on the left with T cells in the tumor. So this is the type of a tumor that is very likely to respond to checkpoint blockade, or an infiltrate there that is just present around the edges. And some of those patients can respond, but they may not necessarily respond as well. Or a tumor that is really devoid of an immune infiltrate. And those are perhaps some of the patients in the study that Dr. Millam shared with us. And so interventions such as CMP-001 really focus on improving antigen-presenting cell function. This is a topic of interest in my group and many other groups. This is a very nice schematic that was put together by Taha Mergoob and Danny Khalil in my group, and they'll be presenting some of their data this afternoon. But really, without a properly activated antigen-presenting cell, we cannot expect there to be a tumor-specific immune response present that can be disinhibited by, say, PD-1 blockade. And so the patients in the study that you just heard about really needed this step over here. They needed activated APCs. You heard from Dr. Milham about the critical role that plasmacytoid dendritic cells play in this pathway, and how TLR9 agonists specifically have activity in these PDCs, and how importantly the number of PDCs may in fact be a very interesting biomarker to look at. So just to review, CMP-001 is quite an interesting molecule. It is a TLR9 agonist by virtue of being a CpG oligonucleotide, and it is coated in a virus-like particle. So we can see that there's an attempt to stabilize the CpG, but also that the VLP itself may have some non-specific adjuvant activity, which does help, and I'm trying to understand actually some of the very rapid responses that Dr. Millam described, because clearly we're not generating new immune responses in just a one-week period of time, but in fact all of this innate activity that we heard about could be mobilized within a few days. Neutrophils, macrophages may actually be able to help in the effector arm of a suboptimal immune response by virtue of this initial TLR stimulus. But then we also see the durability of the response, and that is no doubt due to better priming of a tumor-specific immune response, which is very likely due to the PDC activating step of this. We can see that there's about 20% of patients who respond, which is excellent, and I think that the fact that we've seen responses in both injected lesions and non-injected lesions is, of course, exactly what we would hope to see from an abscopal pointed intervention like this, and that the adverse events were generally quite manageable. I applaud the group for doing interesting translational studies, and I look forward to hearing more about some details of what the specific genes are, what cell types are present in the post-treatment samples of responders and non-responders. And I especially appreciated this visual looking at infiltration, so turning sort of a desert into more of an oasis here. And I'll just point out that using a different way to achieve the same means, my group will talk later today about using another TLR agonist, a monophospholipid A, a TLR4 agonist, along with intratumoral CD40 to achieve a similar goal, albeit in a mouse model. And I just want to point out that one of the things that Dr. Millam's group looked at, which was the increase in PD-L1, we can also say that another intratumoral therapy can do that. This is a mouse model using a CRISPR knock-in where luciferase is placed under the control of the endogenous PD-L1 promoter, where we can see that in both in the injected tumor and in the non-injected tumor, you have an increase in PD-L1 after a single tumor is injected, in this case with a TLR agonist and a CD40 agonist. So in conclusion, the TLR9 agonist CMP-001 can overcome primary or acquired resistance to PD-1 blockade in some patients with metastatic melanoma. The translational biomarkers described so far do support the proposed mechanism of action, and I do think that there should be some attention paid to innate immune cells as effectors early on, so perhaps earlier biopsies would be great to study. How this compares with other strategies pointed in this same clinical scenario, whether it's oncolytic virus, other TLR ligands, or other means of APC activation, remains a question, as does the overarching goal being to understand resistance in an individual patient so that these approaches can be applied in the most appropriate populations. Summarized, how can we identify the 20% of patients whose disease course has seemingly been turned around by CMP-001? What are the precise features that we can look for in patients who we would offer a therapy like this to, as opposed to adding another checkpoint blocking antibody systemically, or adding an oncolytic virus, or other forms of abscopal modulation with something like radiation therapy? So again, congratulations to the group, and thank you for the invitation to discuss.
Thank you, Dr. Walczak, for this excellent discussion. Our next speaker is going to be Dr. Karin Strathoff from the University College in London, who's going to present a study, a phase 1 trial with CAR T cells directed against the GD2 in Thank you, Dr. Fry. Our next speaker is Dr. Todd Feininger from Washington University, who's going to present a first-in-human phase 1 combination of the IL-15 receptor superagonist complex ALT-803 in combination with CD20 inhibition in refractory non-Hodgkin lymphoma.
Thank you. So my disclosure slides here. I would like to point out that this study was funded by an SBIR grant from the National Institutes of Health and Altor Biosciences, a Nantworks company. I think everyone in this room realizes the cancer immunotherapy breakthrough that happened several years ago. And the thing that impresses me is that that breakthrough continues year after year after year. And we now have a plethora of different modalities of cancer immunotherapy at our disposal. Today I'll be talking about a novel phase 1 combination of a very old, tried and true therapy, Rituximab, an anti-CD20 antibody, combined with a relatively new immunostimulatory agent, specifically an IL-15 receptor agonist agent. Interleukin-15 was originally cloned and described by Dr. Waldman's group back in 1994, as well as by the Immunex Corporation. And a number of studies over the last several decades from many different laboratories elucidated the biology of IL-15 and its receptors. IL-15 is produced by a number of different cells throughout the body, but probably most importantly for NK cells or natural killer cells and T cells, antigen-presenting cells, dendritic cells and macrophages. This molecule is the IL-15 receptor alpha, the high affinity component, is produced in concurrence with the IL-15 protein. This is then trans-presented to NK cells or CD8 T cells and some other cells that express the signaling components of the IL-15 receptor, the beta and the gamma chains. This transduces multiple signals through the JAK-STAT pathway, the PI3 kinase pathway, and the RAS-RAF MAP kinase pathway that results in a number of different functional enhancements for natural killer cells. This includes enhancing their activating receptor expression. This is the way that NK cells can in some ways see tumor targets. Their cytotoxic capacity, their proliferation, survival, enhances their metabolic fitness, and can co-activate cytokine production such as interferon gamma. I think importantly for this presentation, it also enhances antibody-dependent cellular cytotoxicity, or ADCC. IL-15 can also augment CD8 T cell responses, enhance their proliferation, co-activate interferon gamma production, and promote memory-like differentiation. ALT-803, the drug that I'll be talking about today, is a superagonist complex, and the structure is shown here. It includes the IL-15 molecule that's been modified to enhance binding to the beta and gamma chains. This is loaded onto a fusion protein that includes the IL-15 receptor, the high affinity binding component, the sushi domain, which is fused to the IgG1-Fc. This results in a physiologic transpresentation of IL-15 to the beta-gamma chain expressed, for example, on the NK cell. In addition, this molecule is much larger than IL-15 as a recombinant human cytokine and results in an increased in vivo half-life. And published work has also shown that it accumulates in secondary lymphoid tissues such as the lymph nodes, which I think is relatively important considering the patient population of indolent lymphomas that I'll be discussing. There's been only a few trials that have been published utilizing IL-15 receptor agonists. The first was back in 2015 from Dr. Waldman's group at the National Cancer Institute, led by Kevin Conlin, and utilized recombinant human IL-15 administered as an IV infusion. And this really was a critical study to identify that this cytokine could be administered and resulted in immune modulation. Just in the last couple of months, additional studies have been published exploring the subcutaneous route for recombinant human IL-15, and 2 papers just in the last few weeks have come out on this compound ALT-803 that I just described. The first was a first-in-human trial in the post-transplant relapse setting, patients who had relapsed following allogeneic transplantation. And the second, literally in just the last week, a combination study of ALT-803 with the anti-PD-1 antibody nivolumab that was published in Lancet Oncology. And I would encourage everyone to go back and read more about these clinical experiences. I won't have time to go over each of these due to time limitations. So the hypothesis for the current trial is really summarized here, where indolent non-Hodgkin lymphoma express CD20, natural killer cells express a receptor for the FC portion of antibody, FC gamma R3A. This can bind to anti-CD20 antibody-coated lymphoma cells, Rituximab in this case, and we're seeking to combine that with ALT-803 and IL-15-based signals. This can result in combined activation of NK cells and enhance their proliferation, survival, metabolism. Also co-activates cytokine production such as interferon gamma, chemokines, and also augment their cytotoxic capacity that results in the elimination through apoptotic-like cell death of lymphoma targets, which is really directed by anti-CD20 antibodies. The hypothesis was tested preclinically in a paper that was already published, combining ALT-803 and Rituximab using in vitro models with primary human cells, as well as in vivo xenografts and animal models, showing that the combination enhances the elimination of lymphoma preclinically. The design of this study was a phase 1 dose escalation, a standard 3+3 design, where Rituximab is given as a standard of care therapy in 4 weekly doses, followed by a rest, where there is 4 additional consolidation doses administered every 2 months. ALT-803 is administered concurrently with the Rituximab at each of these different doses. 2 different routes of administration were tested, the intravenous route at 3 different dose levels, and the subcutaneous route at 4 different dose levels. The eligibility for this trial was indolent non-Hodgkin lymphoma patients that had relapsed after at least 1 prior anti-CD20 antibody-containing therapy. We treated 21 patients with indolent non-Hodgkin lymphoma that included 16 follicular lymphoma patients, which were skewed towards a intermediate and high-risk FLIPI, 4 patients with marginal zone lymphoma, and 1 patient with small lymphocytic lymphoma. The median number of prior therapies was 2, with a very wide range, and 5 patients that were refractory to CD20 antibodies were treated. Initially, ALT-803 was administered IV at 1, 3, and 6 micrograms per kilogram. This was then followed by additional cohorts that were treated through a sub-Q route at the 6, 10, 15, and 20 microgram per kilogram dose levels. Here's the pharmacokinetics of ALT-803 administration in the first 24 hours after the initial dose in the IV cohort. And what you can see is that there's a very high Cmax, a very high level of ALT-803 in the serum of these patients. This is 100,000 picograms per mil or 100 nanograms per mil. Especially at the 3 and the 6 microgram per kilogram dose level, this results in a pro-inflammatory cytokine release systemically, including interferon gamma and IL-6. This resulted in high fevers, as well as rigors and other constitutional symptoms that we've heard about, and is uncomfortable for the patient. These did not reach dose-limiting toxicity levels. They were transient and managed with supportive care. However, because of these high fevers and rigors that required outpatient observation, subcutaneous administration of ALT-803 was explored. Here is the pharmacokinetics showing in the first 24 hours following the subcutaneous administration of 6, 10, 15, and 20 micrograms per kilogram of ALT-803. This did not result in pro-inflammatory cytokine release and did not result in those same constitutional symptoms. And while in this particular study we do not have data going beyond 24 hours for PK, extrapolating from the recently published study in blood, we expect that these levels are probably maintained throughout 96 hours. ALT-803 was well tolerated. There was no dose-limiting toxicities and no grade 4 adverse events. No patients discontinued ALT-803 because of adverse events, and the recommended phase 2 dose was 20 micrograms per kilogram. This was the maximum tested dose. The adverse events that occurred in more than 10% of patients in either the IV or the sub-Q cohorts are shown in this table that were possibly, probably, or certainly related to ALT-803. And I highlighted here one relatively unique reaction that occurred in subcutaneous patients. The patients who received sub-Q Alt-803 developed an injection site rash reaction. This occurs at the site of the injection, starts a few days after the injection, peaks 7 to 10 days later, and then resolves typically within 14 days. These photographs show some of the examples, and in some cases, this can become quite a large area of the skin that's affected. This is self-limited, did not require any systemic therapy, and resolves on its own. As far as responses, between the IV and the sub-Q cohorts, we observed 9 complete remissions, 2 partial remissions, yielding an overall response rate of 11 of 21, or 52%. I think that this is notable in that 11 of the 12 patients who were treated on the subcutaneous cohort remain in follow-up with stable disease or remissions, and only 1 of those 12 patients have progressed. In addition, in patients who were actively progressing on anti-CD20 antibody therapy, we observed 1 complete remission and 2 patients who achieved stable disease with 45% reductions and 36% reductions in their disease burden, their tumor volumes. Here are the swimmer plots in both the IV and the sub-Q cohorts. And again, I'm showing this, the bars are colored by best response, arrows indicate ongoing response, red X's refer to patients being off study due to progressive disease, and the asterisk identifies the anti-CD20 antibody refractory patients. And again, I'm really emphasizing here that there's still a lot of patients that are relatively early in follow-up on this trial in the sub-Q cohort, and I think with another year or 2 of follow-up, we'll really understand the durability of these responses. Here's the change in the SPD from baseline, showing the reduction in tumor volume. This trial also affords the ability to understand the impact of Alt-803 and IL-15 receptor agonists on the immune system, and we employed a number of different techniques to examine the peripheral blood of these patients using both flow cytometry and mass cytometry. This is a Visney plot showing immune compartments within the peripheral blood of one of the patients, identifying natural killer cells here in orange and CD8 T cells in green. And what we observed is that over the 4 weekly doses, an increase occurred in the percentage of natural killer cells, where they became almost 1/3 of all of the circulating lymphocytes. This is also exemplified by an individual patient, where you can see the increase in the density here in the NK cell Visney island over time. We also observe this using more traditional flow cytometry approaches, where NK cells are identified as CD56 positive, CD3 negative lymphocytes. And there was a significant increase in both the percentage and the absolute number of natural killer cells that occurred during this induction phase. Here I'm showing the patients that were treated on the 15 and the 20 microgram per kilogram cohorts, which were significantly increased and about 10-fold as a fold expansion. This is probably due in part due to proliferation. You can use Ki67 as an intracellular marker of proliferation. This is an example patient looking at a flow histogram where after days 5 to 8, greater than nearly 100% of the NK cells were proliferating. And I think it's notable that this proliferative response was sustained through this induction period. There was an absolute fold increase that was significant in the number of Ki67 positive NK cells. We also evaluated intracellular expression of eomase, a TBET transcription factor that's important for NK cell anti-tumor responses and maintains its functionality. We observed an increase in the percentage of eomase positive NK cells and the absolute number of eomase positive NK cells present in these patients after Alt-803 therapy. Now, mass cytometry, because it involves multiple markers, allows you to dial in on individual populations and take a look at some of the types of responses within those individual populations. So in this example, I'm showing natural killer cells, a gate on the natural killer cells, and looking at the changes in the Visney maps over time from day 1 to day 8 to day 22. And you can see that where these cells are located within this Visney map changes markedly over time. Some of those changes are due to changes in specific surface markers. So on mass cytometry, identified the increase in eomase again, as well as increases in the activating receptors, NKP30 and NKP44. CD38, an established marker of NK cell activation, is also increased, as is TIM3, an immunoregulatory molecule. NK cells are not simply CD56 positive, CD3 negative lymphocytes, and can be divided into functionally distinct subsets based on their expression of CD56 and their expression of CD16. Here I'm gating on and highlighting CD56 bright and CD56 dim NK cells. When we examine them for proliferation, we see both cell types proliferating over the course of induction therapy. However, there seems to be a greater persistence of CD56 bright proliferation over time. Importantly, when we evaluate patients who have had the 6-week break and received their first consolidation dose, we saw an induction of Ki67 that was very similar to after the first dose, suggesting that repeated doses of ALT-803, at least after following this schedule, can result in continued NK cell modulation. ALT-803 also expands primed granzyme B positive CD56 bright NK cells. The percentage of this subset increases over time. And this is a subset that our laboratory and others has identified as having the ability to respond to tumor targets. And I think relevant in this situation because this subset of NK cells is preferentially located in secondary lymphoid tissues such as lymph nodes. We evaluated the function of NK cells directly ex vivo, where patients their peripheral blood samples were collected before and 24 hours after ALT-803 therapy. These were used as effectors in a functional NK cell assay where they were stimulated with Rituximab-coated targets for 6 hours. Here's one example of a patient looking at the pre-ALT-803 to the post-ALT-803 in their response to those Rituximab-coated targets, and we see enhanced degranulation, interferon gamma production, and TNF production. We also examined ALT-803's impact on the CD8 compartment and observed a much more modest but significant twofold expansion in CD8 T cell numbers over time. These T cells proliferated, but it was only a subset of T cells that seemed to proliferate, about half of them, and this was more transient than was observed in natural killer cells. Dialing in again on CD8 T cells using mass cytometry, we're able to also look at the heterogeneity and how these cells changed over time during the several time points of the ALT-803 induction. Comparing day 1 to day 8, we see a marked change in CD8 T cells. However, these have returned very similar to their baseline levels by day 22. So what drives this change? We observed an increase in the activation markers CD38 and HLA-DR being expressed by CD8 T cells peaking at day 8 and resolving by day 22, and this was significant. This area of the Visney map localizes to the effector memory phenotype, CD8 T cell compartment. And when we hone in and really zoom in on this particular area on the day 8 samples, we can see that CD38 and HLA-DR are the markers that are identifying this population. Ki67, these are proliferating, and they're expressing CD45RO, EOMAs, and PD1. We examined CD4 T cells and FOXP3 positive regulatory T cells and saw no impact on their numbers over time during this induction course. So in conclusion, ALT-803 is a safe and tolerable IL-15 receptor agonist that can be dosed at up to 20 micrograms per kilogram sub-Q in non-Hodgkin lymphoma patients when combined with a therapeutic antibody. ALT-803 increases NK cell and CD8 T cell activation in number and enhances NK cell function in vivo. There's minimal impact on CD4 and regulatory T cells, at least in the ways that we've looked so far. And I didn't have time to show this, but there's no evidence of immunogenicity against ALT-803 in this study. This might not be surprising considering the concurrent Rituximab therapy. There's an ongoing phase 2 at the 20 microgram dose level divided into CD20 antibody sensitive and refractory cohorts. And based on our data and the very recent publications in Blood and Lancet Oncology, I think ALT-803 is an outstanding candidate for a combination therapy with additional therapeutic antibodies, potentially in other cancers, checkpoint blockade, and potentially other immunotherapy approaches. So with that, I'd like to acknowledge the folks from my lab who performed these studies, Michelle and Ethan, did most of the correlative work. Melissa and Mark performed the CyTOF analysis. Our WashU lymphoma team, as well as our clinical collaborators, Veronica Bacanova and Brian Hess at University of Minnesota and MUSC. With that, I'll conclude my presentation, and I'm not sure if there's time for questions.
Unfortunately, I think we are out of time. Thank you very much for these beautiful data. I think it's really an exemplary body of correlative work, really impressive.
Yeah.
So I'm going to ask Dr. Thomas Waldman from the NCI to join us on the podium.
Well, I'm delighted to have a chance to give my view of IL-15 in combination therapy. I have nothing to declare. It is clear that IL-15 in any of its combinations with IL-15R alpha or E. coli IL-15 alone, whether IV, sub-Q, or by continuous intravenous infusion, can cause dramatic increases in people in the number and state of activation of NK cells, and increase in the number of CD8 cells and their activation. However, due to checkpoints that prevent immunity to cells, some induced by IL-15 itself, it will not work as monotherapy, and rather will have to be used in combination therapy. We have taken advantage of the opportunity to use E. coli IL-15. Here, by continuous intravenous infusion. It has select advantages. It does not have the 30-centimeter skin rash injection sites when you have IL-15 or alpha present, nor cytokine release syndrome, and has the greatest effect on the number and state of activation of the NK and CD8 cells. So when one administered by continuous infusion, as you see in the red arrows, you see initially a depletion entirely of NK cells within moments. But then when you stop the IL-15, the cells return, so that there is an increase at 2 micrograms per kilogram per day, 30-fold in the number of NK cells, whether the infusion is 10 or 5 days. And the number of CD56 bright NK cells increases 350-fold. So why doesn't it work? Well, the checkpoint, of course, is class 1 MHC, seeing, for example, care, turning off the NK cells. So one must use it in combination therapy. Here in this model, we have EL4 cells in a fully syngeneic, completely immunocompetent mouse, transfected with human CD20 and Rituximab as the agent. What one sees is when one uses IL-15 alone or the antibody alone, it shows only modest effect. But the combination cures 80 to 100% of the mice. In a xenogenetic model of adult T-cell leukemia caused by HTLV1, one sees with anti-CD52 a response in red on your left, very little with IL-15 yellow on your left, but the combination in green shows much greater action. In either of these models, if you have an FC receptor gamma knockout mouse, that is no ADCC, you lose all activity. So what cell is involved in this process? There are most of you that thinks it's an NK cell, but Jeff Ravitch, our collaborator, won't let me say that. He absolutely insists it's a macrophage. And in fact, it turns out that they are both elements in a chain of causation that results in the effective NK cell. That is, if you knock out NK cells, as shown in green, you lose activity in this EL4 anti-CD20 model. But if you knock out macrophages, as shown in blue, you also diminish the activity. And what it turns out is that initially in this model, one cannot do ADCC without the trio. That is, IL-15 in the context of macrophages, the NK cells interact with the macrophages with IL-15, and there is the induction in the NK cell of Fc receptor gamma 4, which is absolutely essential for it to do ADCC with the human IgG1 Rituximab. So the effect of IL-15 is not only in magnitude of number of cells, but also changes them in terms for human CD16, NKG2D, both. And so we have entered into a number of models with a combination. The one that is active involves the administration of IL-15 initially, and then the anti-CD52 Campath-1 or Rituximab. And here, 2 patients have been studied, and the second of those patients who has adult T-cell leukemia, starting with about 20,000 leukemic cells per cell, being given IL-15 and alemtuzumab, is now 200 days later still in a complete response. We are having in regulatory control obinutuzumab plus IL-15 for patients with relapsed or refractory leukemia, avelumab with renal cell cancer and IL-15, and with certain T-cell malignancies. And also we're studying the combination of IL-15 with anti-PD-1 and anti-CTLA-4. But what's happening with CD8 cells? If you give IL-15 by continuous infusion to rhesus macaques, you can increase the number of circulating effector memory CD8 cells to 80 to 100,000 per cubic millimeter, an unbelievable number. But they don't know what the hell to do, in the sense that there's no evidence that they have tumor cell specificity. Well, again, we have a checkpoint. And we were shown this by Sikosil. That is, when you give a gamma cytokine like IL-2 or IL-15, you induce in the CD4 cells SOX3. And with that, the CD4 cells have no value. CD8 cells are there, they continue, they expand, but they are not tumor cell specific. 6 groups, including our own, showed that you do not need helper cells in this system, but CD40 agonist is what you need. And that is, if you have CD40 agonist, here's our own study in the TRAMP-C2 prostatic tumor model. If you have CD40 agonists, now you have very effective CD8 mediated, IL-15 mediated response. That is, here in this model, IL-15 alone on your left, yellow, very little. The anti-CD40 alone in red, modest, but the 2 together always cure 80 to 100% of the mice. And if on your lower right you look at the bitetramer for tumor-specific CD8 T cells, it is only when you have the combination of IL-15 plus anti-CD40 that you see the induction of such tumor-specific cells. So we've joined with Jeff Ravitch to use an optimized anti-CD40 given intratumorally with continuous intravenous infusion of IL-15, an action which in mouse models works very well and we'll see in people. So our own view, again, to reprise, is that IL-15 alone will not be effective in sufficient number of patients, but that there are combinations of agents which already have tumor efficacy that can be made much better by the ability of IL-15 to induce NK cells and membrane effector CD8 T cells. Thank you.
Thank you, Dr. Waldman. speaker, and we're continuing the theme of natural killer cells, is Dr. Sakamoto from the Kyoto Prefectural University of Medicine. He's going to talk about a clinical trial, phase 1, safety and efficacy of high purity and activity of NK cells in combination with IgG1 antibody in patients with gastric or colorectal cancer.
Thank you, Mr. Chairman. It's a great honor to speak here today. I'd like to thank the program organizing committee for providing us with a great opportunity to present our recent work. Today, I will talk about phase 1 clinical trial of adaptive transfer of expanded NK cells in combination with IgG1 antibody. I have no financial relationships to disclose. This slide shows the contents of my presentation. As you can see, there are 4 parts. First, I'll give a short introduction. Second, I'll describe our recent phase 1 clinical trial of adaptive NK cell monotherapy. Third, I'll focus on phase 1 clinical trial of NK cell therapy in combination with IgG1 antibody. Finally, I'll finish with a brief conclusion. I'd like to start with part 1, the introduction. I'd like to give some background information. Natural killer cells kill tumor cells by natural cytotoxicity, but they can also be activated upon binding of antibody to Fc receptors on their surface, thereby mediating ADCC. NK cell-based adaptive immunotherapy is a promising approach for the treatment of cancer. But unlike T-cell expansion, it is difficult to generate the sufficient scale and purity of NK cells, and reliable method to produce large number of functional NK cells have not been established yet. We have developed novel clinical grade NK cell expansion method to produce the high purity, large-scale and functional NK cells using recombinant human fibronectin fragment called retronectin-induced T cells for stimulation. In cancer patients, immune effector cells, including NK cells, are often deficient and dysfunctional. In addition, due to cytotoxic treatment regimens, the immune system can be temporarily dysfunctional with the degrees in immune effector cell subsets. Such limitation could be overcome by adaptive immune cell therapy. I'll describe our recent phase 1 clinical trial of adaptive NK cell monotherapy. This clinical trial was conducted to evaluate the safety and efficacy of autologous NK cell therapy using novel expansion method, and I'll address the characteristics of the NK cell elicited by this method and the results of immune monitoring. I'm going to explain NK cell expansion method. PBMC were separated from cancer patients' peripheral blood and then were suspended in culture medium that was pre-coated with both anti-CD3 and retronectin, which is recombinant human fibronectin fragment. Cells were cultured in a medium supplemented with recombinant IL-2 for 1 or 2 weeks. After irradiation, cells were used as simulators for NK cell expansion. PBMC were resuspended in culture medium supplemented with IL-2 and OK432. On days 21, the cultured cells were harvested. I'll mention study design. This was non-randomized open-label phase 1 clinical trial with dose escalation of NK cells. The primary endpoint of this study was to assess the safety of the NK cells derived from our method. And the secondary endpoint was to evaluate clinical and immunological responses. As you can see here, patients were administered autologous NK cells 3 times weekly via intravenous infusions for 60 minutes. Blood samplings were done on day 0, day 14, and on 42 days, 4 weeks after the 3rd administration. 14 patients were enrolled in this trial. This table shows patient demographics and clinical characteristics. 7 patients had colorectal cancer, 4 had esophageal cancer, and 3 had gastric cancer. I'd like to give some data of expansion and NK purity dynamics. The median of total cell and NK cell expansion rate after cell culture was 586-fold and 4,724 respectively. As shown on the right side of this slide, the purity of expanded NK cells markedly increased after culture. Next, I'd like to give some data of characteristics of expanded cells. Expanded NK cells highly expressed cell surface markers such as NKG2D and CD60, which are considered viable and functional markers of NK cells. In this slide, I'll show you clinical response. No patient showed tumor shrinkage. In the per protocol analysis, the response rate and disease control rate were 0 and 50% respectively. We directly tested cytotoxicity of each patient's final product. Expanded cell from all patients exerted strong cytotoxic activity. Immunological monitoring demonstrated that, as you can see in the left graph, the average NK cell population in peripheral blood lymphocyte slightly increased until day 42 after NK cell administration. The population of NK cell in cohort 2 and 3 gradually increased after the infusion of NK cells. Next, we tested cytotoxicity of PBMC against target cells. We found cytotoxicity increased in 80% of patients after NK cell infusion. As you can see in the right graph, on day 14, average of PBMC cytotoxicity increased more than twice compared to the day 0 baseline value. It was noted that the average of PBMC cytotoxic activity in patients with SD increased more than 3 times on day 14. I'd like to give you results of our clinical trial of NK cell monotherapy. Our expansion system is effective to generate large number of fully functional NK cells, even in patients with advanced cancer. And NK cell monotherapy is very well tolerated. Immune monitoring demonstrated that cytotoxicity of peripheral blood was elevated approximately 2-fold up to 4 weeks after NK cell administration. However, definite clinical responses were not observed. This observation emphasizes the need for combination strategy to fully exploit the potential of adaptive NK cell therapy. Third, I'll focus on phase 1 clinical trial of NK cell therapy in combination with IgG1 antibody. This clinical trial was conducted to evaluate the safety and efficacy of the administration of NK cells generated by our novel expansion system in combination with trastuzumab or Rituximab. I'll mention study design. This was non-randomized open-label phase 1 clinical trial with escalation of NK cells. Primary endpoint was to evaluate the safety, the combination of administration NK cells derived from our method and IgG1 antibody. The secondary endpoint was to assess clinical and immunological responses. Treatment consisted of trastuzumab or Rituximab-based chemotherapy plus adaptive NK cell therapy. As you can see in this slide, combination therapy was given every 3 weeks. Expanded NK cells were intravenously injected for 60 minutes, 3 days after IgG1 antibody administration, every 3 weeks for 3 cycles. 9 eligible patients were enrolled in this trial. This table shows demographics and clinical characteristics. 3 patients had gastric cancer and 6 had colorectal cancer. Of the 9 patients, 7 had received prior chemotherapies before the enrollment of this clinical trial. All patients except 1 received 3 NK cell administration. 1 patient had disease progression and therefore received only 2 administrations of NK cell therapy. I'd like to give some data of cytotoxicity of expanded NK cell. We directly tested cytotoxicity of each patient's final products. As you can see in this slide, expanded NK cell from all patients exhibited strong cytotoxic activity. We also checked ADCC activity of each patient's final product using HER2-positive cell lines and EGFR positive cell line. Cytotoxicity of expanded NK cells alone against these target cells was relatively low. However, co-incubation with trastuzumab or Rituximab resulted in a significant increase in these cell deaths. Thus, expanded NK cells exerted ADCC activity both in HER2-positive cell line and EGFR-positive cell line exposed to IgG1 antibody. In the next 2 slides, I'll show you clinical efficacy. 1 patient was not available due to incomplete treatment. 2 patients had no target region according to RECIST criteria. Consequently, of the remaining 8 patients, treatment response was evaluated by computed tomography in a total of 6 patients. Compared to baseline, target region diameters 4 weeks after the last NK cell administration decreased in 3 patients. But these 3 patients did not achieve an objective partial response according to RECIST criteria. Of the 6 evaluable patients, 4 demonstrated stable disease and 2 demonstrated progressive disease. No adaptive transfer NK cell-related severe or unexpected toxicity was observed. Time to progression of 3 patients with tumor shrinkage was 664, 304, and 231 days, respectively. Thus, long-lasting disease stabilization was observed in these patients. In the next 4 slides, I'll show you data of immunological monitoring. Whole blood stimulated with PHA for 48 hours, after which the supernatants were harvested. Cytokine levels were measured with a multiplex cytokine assay system. As shown here, the levels of all cytokines except for GM-CSF increased after administration of NK cells. It is noteworthy that levels of interferon gamma and IL-2 7 days after NK cell administration, follow-up 1, was significantly increased compared to baseline. Both interferon gamma to IL-4 ratio and interferon gamma to IL-10 ratio from follow-up 1 were also increased significantly. These results indicate that this combination therapy could strongly enhance a Th1 type immunoresponse. Both number and proportion of Tregs in peripheral blood decreased following treatment. These were not significant changes, but the trend continued during follow-up. As you can see here, there was no significant change in serum cytokine levels after treatment. I'd like to show you results of this clinical trial. NK cell population expanded with our system was enriched in NK cell with high expression of NKG2D and CD16. Expanded NK cell exerted ADCC activity in both HER2 positive cells and EGFR positive cells. This combination therapy was very well tolerated. Among 6 evaluable patients, 4 presented SD, 3 showed an overall decrease in tumor size, and long-lasting disease stabilization was observed in these patients. Immune monitoring suggested that combination therapy enhanced whole blood interferon gamma production and reduced peripheral Tregs. I'll conclude my talk with a brief summary of the main points. We developed a novel clinical grade and large-scale NK cell expansion system using recombinant human fibronectin fragment called retinol-nectin induced T cells for stimulation. Our trial provides evidence of good tolerability, induction of Th1 immune response, and preliminary anti-tumor activity for the combination of adaptive NK cell therapy and IgG1 antibodies. It would be interesting to examine whether the enhancement of NK cell function by administration of expanded NK cell can overcome resistance to IgG1 antibody. I would like to acknowledge the people who worked with us on this project. Thank you very much.
Thank you, Dr. Sakamoto. Now I'm asking our last discussant, Dr. William Carson from Ohio State University, to join us on the podium.
Thank you. Today I'll be discussing the science behind NK cell therapy of cancer. I have nothing to disclose. So congratulations to Dr. Sakamoto of Kyoto, Japan, in the study entitled Safety and Efficacy of High Purity NK Cells in Combination with the IgG1 Antibody in Patients with Gastric or Colorectal Cancer. So let me introduce you to the basic natural killer cell, starting with the IL-2 receptor and going clockwise. NK cells constitutively express a number of cytokine receptors and are greatly activated by these cytokines. They also express a receptor for the Fc, or constant portion of the IgG known as CD16. They possess abundant levels of granzyme and perforin that let them lyse cancer cells. They are marked by their expression of CD56. And they also express killer cell immunoglobulin-like receptors that send a negative signal in the presence of normal cells with high levels of MHC class I, and tend to have this signal turned off in the presence of cancer cells with low levels of MHC class I. The NK cell can target cells without prior sensitization. They can lyse antibody-coded target cells, and they are very efficient producers of cytokines like interferon gamma, TNF-alpha, and chemokines like MIP-1 alpha. So let's summarize the study we just heard about. PBMC cultures were with OK432, IL-2, and fibronectin-induced T cells. The phenotype was NK at 93% CD56, and they expressed NKG2D, an activating receptor, and CD16. Cell function was good with 90% cytotoxicity versus K562. Patients had advanced gastric or colorectal cancer. The dose levels are right there for you to see, 0.5, 10 to the 9th cells starting. Therapy was 3 times with or without monoclonal antibodies. Safety was good. There were no severe adverse events, and in the final study, there were 66% of patients with prolonged stabilization of disease. So what are some of the challenges in NK cell therapy? How can we improve it? Well, we want NK cells to be expanded. We'd like the NK cells to traffic to the tumor once expanded. They need to be activated. We like the NK cell to target the cancer cell specifically, and we're interested in NK cell longevity and also biomarkers of activity. So here's our NK cell in the tumor microenvironment. We'd like them to be expanded. We'd like them to be trafficking to the tumor, not away. We'd like to see activated NK cells in that area that are then targeting the cancer cell specifically. NK cell longevity is nice to see. And then along the way, we want to develop biomarkers of activity, looking at things like interferon gamma production. So let's get to work. NK cells can be expanded in vivo via cytokine therapy or ex vivo in bulk cultures. Many of these strategies make use of the fact that NK cells constitutively express a low affinity IL-2 receptor, and there is also a subset with the heterotrimeric high affinity IL-2 receptor. Dr. Fleming of Michael Caligiuri's group showed that NK cells can be expanded simply via the subcutaneous administration of low-dose IL-2 in the range of 1 million units per day per meter squared. And as one can see in the bar graph and also in the far right dot plot for CD56 and CD16, the number of NK cells in the upper quadrants is markedly increased in patients post-IL-2. The recipes for ex vivo expansion of NK cells calls for cytokines and activation signals, which can be feeder cells, such as K562 leukemia cells, or fibronectin stimulated T cells, as was the case with Dr. Sakamoto's study. Irradiated peripheral blood mononuclear cells are effective, as are Epstein-Barr virus infected lymphoblastoid cell lines. Dr. Fujisaki of Dr. Campana's group used a K562 cell line that had been engineered with membrane-bound IL-15 and 4-1-BBL as a stimulator in combination with IL-2, and they effectively were able to expand NK cells ex vivo. Then we have NK cell trafficking to the tumor. And the question is, how can we direct NK cells to the tumor? Well, we can think about doing intraarterial infusions or intratumoral NK cell injections, or one can just simply study cancers of the blood, lymph, or liver, because that's where NK cells tend to track to once they're infused. Or we can think about increasing levels of tumor cell adhesion molecules. Jae Jung of Dr. Cho's group in Korea showed that irradiation upregulates expression of the ICAM1 adhesion molecule on cancer cells and enhances NK cell cytotoxicity through its ability through LFA1 to recognize the increased adhesion molecules, and you get increased tumor cell stickiness. Thus, one can imagine going forward the irradiation of a tumor occurring in conjunction with NK cell infusions. Now, what about NK cell activation? There are a number of factors that can do this for us. The tried and true method is interleukin-2, but other cytokines have been shown to be very effective in activating NK cells, including IL-12, IL-15, IL-18, and IL-21. NK cell express toll-like receptors, and they can be stimulated with agonists. Other ligands, such as ligands for the NK G2D activating receptor, can be used, or KIR blockade, which is a negative on a negative and therefore a positive way to stimulate NK cells. Or one can inhibit myeloid cells or their products like nitric oxide. Dr. Rosario and Dr. Offeniger's group showed that combining an IL-15 agonist with an anti-CD20 monoclonal antibody against CD20 was able to treat SCID mice that were bearing a lymphoma, a human lymphoma. And as you can see, the combination therapy was significantly better than control treatments, and we saw the outcome of this in his clinical trial today. So what about NK cell targeting? We know that NK cells express a receptor for the constant or FC region of immunoglobulin G, and there are multiple FDA-approved monoclonal antibodies out there, there are several lines of evidence suggesting that NK cells contribute to tumor shrinkage in the clinical usage of these antibodies. Thus, monoclonal antibodies are a perfect platform for targeting and activating NK cells and can be modified accordingly. So here's what might be happening with targeting using an antibody. Above, we have a HER2/neu overexpressing cancer cell that is coated with trastuzumab, the HER2/neu monoclonal antibody, and engaging it is a CD16 positive NK cell that is able to conduct antibody-dependent cytotoxicity and release pro-immune cytokines like interferon gamma, TNF alpha, and MIP-1 alpha, which will draw in T cells to join the fight. NK cell targeting has been advanced using engineered antibodies. One example is the trispecific natural killer cell engager, or TRIKE, developed by Dr. Jeff Miller's group. This molecule has 3 components. There's a single chain fragment variable specific for CD16 on NK cells, a single chain fragment variable specific for CD133 on the cancer cell, and then IL-15. So you can imagine this bringing the NK cell together with the cancer cell and also stimulating it. This reagent and many others are currently in development in multiple laboratories. Increasing NK cell longevity would also be useful. NK cells can be engineered to express genes associated with survival, like telomerase, or one can use other methods, such as that used by Dr. Williams, who employed the NK92 cell line that was isolated from NK cell leukemia. And this group conducted a phase 1 clinical trial using this long-lived cell type, doing infusions in patients with refractory hematologic malignancies. And they showed that in 2 patients there was a complete response just by simply infusing this cell. 2 others had minor responses, and several had clinical improvements. So what are the biomarkers of NK cell activity? We could look at antibody-dependent cytotoxicity, or levels of granzyme B and perforin in the NK cells. FC receptor polymorphisms. Everybody in this room has NK cells with high, medium, or low ability to recognize antibody-coded targets, and that can be measured looking at single nucleotide polymorphisms. In addition, we can look at cytokine profiles like interferon gamma, MIP-1 alpha, RANTES. Our group conducted a clinical trial of interleukin 12 as a NK cell activator. And we gave that in combination with trastuzumab and paclitaxel. We measured multiple cytokines over time and showed in this complete responder that the levels of cytokines increased over time for many months. In fact, out of 21 patients in this study, there were 5 responders and 6 stable disease patients, and 2 of these stable disease patients were GI cancer patients that went on for a full year. And as you can see, interferon gamma was elevated in the patients with high level, with a clinical benefit, and very low levels in progressive disease patients. Other promising approaches are CAR-NK cells. These are chimeric antigen receptor NK cells that are delivered with a lentiviral vector, and also anti-KIR blocking antibodies are being used clinically. So in summary, NK cells can be expanded in vivo and ex vivo. There are multiple NK activating strategies. Trafficking and targeting are under investigation, and CAR-NK and anti-KIR strategies do hold promise. What we do need are more precise biomarkers that can tell us who's going to respond to these therapies early on in their therapy. Thank you very much.
Thank you, Dr. Carson. This will conclude this clinical trials plenary session. I'd like to commend all the presenters for their carefully conducted clinical trials and the extensive efforts to learn from these studies through correlative work. And of course, I also want to thank all the discussions for their insights and comments. Thank you.